Okay, welcome everyone. Good evening or good morning, good afternoon, depending on where you are in the world. My name is Jasper Schipperijn. I'm the ISPAH president, and I'm very happy to welcome you today to the second webinar in our series looking at the WHO guidelines on physical activity and sedentary behavior. And today we are looking at why and how to reduce sedentary behavior. We have lined up a group of 5 speakers that will give you an insight in the different aspects of sedentary behavior, the evidence, the practice, the intervention, the language to use. So we hope to give you another good look behind the scenes of the WHO guidelines. So on behalf of ISPAH, I would very much like to welcome you to this second webinar that we are hosting together with WHO. And I would like to welcome Fiona Bull on behalf of WHO to also say a few welcoming words. Fiona.
Thank you very much indeed, Jasper, and a very good evening, a good afternoon, and a very early good morning if you're joining us from Australia or New Zealand or Asia. I'm Fiona Bull, and I'm the head of the Physical Activity Unit at WHO headquarters in Geneva. And it's a great pleasure to participate and invite you and welcome you to this session. This is the second in a series of webinars that we're really pleased to participate and collaborate with ISPAH on. Since the launch of the guidelines, it's vital that we continue to maintain the momentum and disseminate and increase everyone's understanding about the guidelines, what the science is, how to use the guidelines, so we can inform policy, practice, and of course the research agenda. There were gaps in knowledge, and so the research agenda is equally vital that we stimulate the new research needed to inform the next guidelines. Today's session, of course, focused on sedentary behaviours is particularly important because the new guidelines of 2020, this is the newest piece of information, the first guidelines from WHO on sedentary behaviours. So it's a great lineup of presentations, opportunities for Q&A to really understand the science and start to discuss how we communicate, the language, and how we implement through programs, policy, and practice. So welcome, let's get started, and back to you, Jasper.
Thank you very much, Fiona. Yes, there is, as Fiona was saying, there is, of course, as you are used to from us by now, there is the opportunity for questions and answer. And for that, please use the question and answer button in the bottom of your screen. So not the chat function, but the question and answer function there in the bottom of your screen. You're very welcome to engage on social media as well during this webinar. Please use these hashtags and these links. And with that, I would like to welcome our first speaker of today, Ulf Ekelund from the Norwegian School of Sports Sciences in Norway. And he will talk to us about the evidence behind the new WHO sedentary behavior guidelines. Ulf, the floor is yours. I'll stop sharing my screen and you can start sharing your screen.
Thanks for the introduction, Jasper. I hope everybody can see my screen. So I will spend the next about 20 minutes to discuss and briefly summarize the evidence behind the new sedentary behavior guidelines. I will very briefly start discussing the guidelines for children and adolescents aged 5 to 17 years, and then mainly focusing on the adult guidelines. So the children and adolescent guidelines states that children and adolescents should limit the amount of time spent being sedentary, particularly the amount of recreational screen time. It's a very general guideline with no specific recommendation on duration of sedentary behavior. And it's a strong recommendation, but with low certainty evidence. So what is basically the evidence behind this guideline? Well, if we're going to summarize it very, very quickly, we know that there is low quality evidence suggesting that greater time spent sedentary and especially recreational screen time is associated with a number of poorer health outcomes, such as poorer fitness, poorer cardiometabolic health, and so on and so forth. However, we also know that certain types of sedentary behaviors are associated with better academic achievement. When we looked into these guidelines, we also looked at the dose-response association, and we couldn't find, or there was insufficient evidence for a dose-response association between sedentary behaviors and the health outcomes we were interested in. We couldn't find any specific types of sedentary behaviors because the evidence was hardly not there. So we deemed that this evidence was insufficient. And most of the evidence are cross-sectional and based on self-reported sedentary behavior, and thereby the certainty of the evidence is deemed as low certainty. We also know, we observed some of the systematic reviews we looked at, it looks like the health outcomes are attenuated or eliminated when studies have statistically controlled for moderate to vigorous intensity physical activity. But just to summarize this, the current evidence do not really justify a quantitative recommendation on sedentary behavior in young people. So the guidelines for the adults, older adults, and those older adults living with chronic conditions and with disabilities are phrased exactly the same for all these groups. Adults should limit the amount of time spent sedentary. Replacing sedentary time with physical activity of any intensity are associated with health benefits, and to help reduce the detrimental effects of high levels of sedentary behavior on health, adults should aim to do more than the recommended levels of moderate and vigorous intensity physical activity. For adults and older adults, this is a strong recommendation because the benefits by far outweigh the harm. And for older adults and older adults, it's moderate certainty evidence. However, for those living with chronic conditions and with disability, the evidence is considered as low. So briefly on the methodology, these are the questions we try to address. Is there a dose-response association between sedentary behavior and health-related outcomes? Does the association vary by type or domain of sedentary behavior? And the third question was about whether physical activity modified the effect of sedentary behavior on mortality. We looked at the number of critical outcomes. We looked at all-cause and cause-specific mortality, incident CVD, incident cancer, and incident type 2 diabetes. And we also looked at adiposity or prevention of weight gain. We did a systematic literature search, and we based that one on the 2018 American Physical Activity Guideline Advisory Committee report and updated the search from the point in time where they finished their search. The level of evidence were graded according to the grade. And basically you grade the level of evidence from very low to high. And in this case, we can't basically grade the evidence as high because this grading is primarily for randomized controlled trials where a high level of evidence is needed, or a randomized controlled trial is needed to provide a very high level of evidence. So most of the evidence we consider were moderate or low, low levels. So just to give you a little bit of a flavor of those studies that informed, or those systematic reviews that informed the evidence for these guidelines. So just going to give you a short overview of some of the studies. We looked at sedentary behaviors and mortality. So this is one of the studies we evaluated, a very large systematic review looking at all-cause mortality, cardiovascular and cancer mortality, and incident type 2 diabetes. More than 1 million individuals were included in this systematic review, and the aim of the review was to examine the strength and shape of the dose-response associations between sedentary behaviors and those critical health outcomes. And also, they also looked at those studies who took physical activity into account. Basically, to summarize the conclusion from this systematic review was that independent of physical activity, total sitting time and TV viewing time are associated with greater risk for several major chronic disease outcomes. They also, in this systematic review, estimated or looked at the dose-response association, and they observed a 4% increase for all-cause mortality for each hour spent sitting above 8 hours. And this was after statistically controlling for moderate and vigorous intensity physical activity, suggesting that sedentary time or sedentary behaviors are associated with all-cause mortality independent of physical activity. They defined a threshold of about 6 to 8 hours for total sitting time, and above that threshold, the risk of death increased, not exponentially, but curved linearly. Another study we examined was this study who looked at the associations between both physical activity and sedentary time measured by accelerometry and the risk of all-cause mortality. So in this study, which included about 40,000 individuals from 8 different studies, we also found, and this is a bit busy slide, but it basically shows the dose-response associations between physical activity and sedentary time. And if you look at the bottom of the table, you have sedentary time. That quartile 1 is the least sedentary, or those ones who have the least amount of sedentary time. They accumulated about 7.5 hours of sedentary time per day. And you can see a nice, clear dose-response association with increasing quartiles for sedentary time. And the risk of death is more than twice as big in those ones who accumulated about 11 hours of sedentary time per day. And these analyses were also adjusted for moderate and vigorous intensity physical activity. So again, it confirms the other observation that this seems to be independent of physical activity. Again, looking at the dose-response association, quite somewhat different from the previous systematic review, which were mainly based on self-reported sedentary time, because in this review, using accelerometry to measure sedentary time, there was an increased risk above 9 or 9.5 hours per day. So it's slightly different from the previous review. We also, as I said, looked at other outcomes, such as critical outcomes, such as cardiovascular cancer and type 2 diabetes incidence, and looked at the association between sedentary behaviors and these critical outcomes. And to give you one example, one of the more recent meta-analysis looking at sitting time and the incidence of cardiovascular disease and type 2 diabetes. In this study, again, mainly based on self-reported data or entirely on self-reported data, they compared the highest sitting group with the lowest sitting group for each of these studies, and then meta-analyzed the results from 5 studies looking at cardiovascular disease and 5 studies looking at type 2 diabetes. And again, all these studies adjusted their analysis for physical activity. And you can see for cardiovascular disease, the risk for those ones with high sitting time compared to those ones with low sitting time is about 29% greater. And for type 2 diabetes, the risk is about 13% greater. But again, suggesting that sedentary time is associated with these outcomes and higher sitting time increases the risk of incident cardiovascular disease and type 2 diabetes. So the other question, or the third question we wanted to address, is whether the association between sedentary behaviors and mortality vary by levels of physical activity. And that basically means whether the slope or the association between sedentary time or sedentary behaviors with mortality is different between those ones who are inactive compared to those ones who are active. And in the American Physical Activity Guideline Advisory Committee report, they used this paper to illustrate the combined associations between sitting time and physical activity on all-cause mortality. In this paper, we looked at the joint and stratified associations between sitting time and physical activity with all-cause mortality. And if you look at those ones who are physically inactive, there is a clear dose-response association between greater or higher amounts of sitting time with mortality. In the two middle groups or middle quartiles, there is an association that is less pronounced, whereas in the most active quartile, or in this case about 250,000 individuals, there seems to be no association with sitting time and mortality if you are highly active. We then went on and looked at physical activity, sitting time, and cardiovascular and cancer mortality. And this study also informed the new WHO guidelines. And in this study, based on the more or less the same data set as the previous study, we examined the stratified associations between physical activity, sedentary time, and both CVD and cancer mortality. And basically this addresses the question whether the association between sedentary time or sitting time with mortality differs by different levels of physical activity. So just look at the data for CVD mortality. You can see the 16 different groups. The inactive group or the inactive quartile at the top cross-categorized for sitting time, and then the highly active group at the bottom or the highest quartile for physical activity also cross-categorized by sitting time. And in each of these four groups, the lowest sitting time is the reference group. And again, a clear dose-response association between sitting time and CVD mortality in the inactive individual, in the inactive group, whereas in the middle group, the association is less robust and less clear, and in the most active quartile, there is no association between sitting time and risk of mortality from cardiovascular diseases. The pattern is very similar for cancer mortality. Again, in the inactive quartile, there is an increased risk by higher sitting time, especially if you sit for more than 8 hours per day, whereas in the other three quartiles, there is a less pronounced risk, and in the most active quartile, there is no risk at all with increased sitting time. So these data then may suggest that physical activity can modify the association between sedentary time and risk of mortality. Another study also using the same data set as I previously showed you for accelerometer data. This study was not part of the WHO guideline advisory committee report, but it was published in the same issue as the newly released guidelines. In this study, we looked at the association between sedentary time by accelerometry and physical activity, or moderate and vigorous physical activity. And the pattern is very similar to what we see from self-report, not as pronounced, but very similar. So if you look at the most active tertile who spent about 34 minutes per day in moderate and vigorous physical activity, there is an increased risk, but it's not statistically different from the reference group. In the group who were active for about 11 minutes per day, combined with low sedentary time, there is hardly any difference with the referent, whereas in the least active tertile, only doing about 2 minutes of moderate intensity per day, the risk with sitting time is pronounced, and it's about 65 to 163% higher compared to the reference. But again, suggesting that physical activity, at least a certain amount of physical activity, can attenuate the association between sitting time and or sedentary time with risk of death. So the question we wanted to address whether the association between sedentary behaviors and mortality vary by levels of physical activity. And the answer to that question, at least based on the evidence we reviewed, is that physical activity modifies the association between sedentary behaviors and risk of death, and physical activity can therefore counteract the detrimental association between sedentary behaviors and risk of death. So, to summarize this evidence very briefly, we observed a moderate quality evidence for dose-response association between sedentary time and all-cause CVD and cancer mortality and CVD incidence. There was low quality evidence suggesting a dose-response association between sedentary behaviors and incident cancer and type 2 diabetes. There were low or insufficient evidence for an association between sedentary behaviors and adiposity and prevention of weight gain. So those were our main critical outcomes, and the evidence differed depending on the outcome. We observed moderate quality evidence for the association between sedentary behaviors and all-cause and cardiovascular and cancer mortality vary by level of physical activity, suggesting that it might be possible to circumvent the detrimental effects of sedentary behaviors by being physically active. We also concluded that there is insufficient evidence for type or domain of sedentary behaviors, and that's definitely an area for future research. And there was insufficient evidence for breaking up sedentary behaviors on these critical outcomes. We know that there is evidence for other important outcomes, but not for the critical outcomes we defined before we reviewed the literature. So in summary, the current evidence is insufficient to quantify a threshold for sedentary behaviors according to the WHO expert group. And we think that physical activity and sedentary time can be combined differently to reduce the risk. This is a slide from, I forgot to include the reference, but this is the publication by Paddy Dempsey, published in IJBMPA, along with the WHO guidelines. So it's possible to come into this green zone or the low risk zone by being highly sedentary and also highly physically active, or having a low amount of sedentary time and a little bit more of moderate and vigorous intensity physical activity. But there are many ways how these two behaviors can be combined to reduce the risk of mortality. So this is some of the evidence behind the two recommendations you've seen before. As I said, for adults and older adults, it's a strong recommendation. The evidence is moderate. For the other groups that other groups looked at within the expert group, the evidence was deemed as low. So I just want to finish off by thanking the Sedentary Behavioral Guideline Working Group, and they are on this slide. Thank you very much.
Ulf, thank you very much indeed for that extensive coverage of an enormous amount of research. You've done a great job there, and we invite you now to draw breath, but also to look in the questions. The Q&A is already rapidly accumulating a number of important questions, and so we will turn to the Q&A shortly. And thank you to the audience for posing questions about how we measure sedentary behavior, questions about potential residual effects, residual effect modification, questions about mechanisms, how is sedentary behavior detrimental? And a big question, when could we expect quantified guidelines on sedentary? So we'll return to those. But one of the important aspects of the WHO guidelines was ensuring that they speak to everyone. And the inclusive agenda was first and foremost at the whole design approach and methods used. to include people of all ages and people of all abilities, and including people with disabilities. And in this area in particular, it really poses some challenging language. And we heard and saw in some of those graphs the use of sitting as a way, as a proxy, as a term to refer to sedentary. But in fact, for some people, sitting is actually what they do all day. And I'm absolutely delighted to invite Sarah Brown-Fraser to join us to speak from her experience, personal and professional, about the challenges and barriers of being physically active and indeed communicating guidelines on physical activity and sedentary behaviours. Language matters. And Sarah, I'm going to hand the floor over to you for some remarks about how we all can learn and do better at this to make sure we're inclusive and engage everyone. Sarah, the floor's yours.
Thank you. Thank you. Hello, everyone. So it's lovely to be part of this event today, and I've been asked to talk for 5 minutes on the importance of inclusive language. So that's a short time to reveal everything I know, but hopefully you'll get a flavour of my professional and personal passion on this very topic. So by day, I lead the Marketing and Communications for Activity Alliance in the United Kingdom. We're the national charity and leading voice for disabled people in sport and activity. And we were founded over 20 years ago and have a wealth of insight and resources. Please do visit our website to find out more. So part of my work includes inclusive language. That is, using positive and accessible language that ensures disabled people are not spoken or written about in a negative way. Negativity creates stereotypes and misconceptions that lead to things like low self-esteem, low self-worth, and so much more. And I can tell you that this is always the area that most people are afraid of. I get questions like, what should I say? What if they don't like it? What if they're offended? You know, and when you scale it up on a global scale, you find more terminology, references, and variations and different beliefs on language as well. So here in the UK, Activity Alliance follows something called the social model. Please do look it up. It is a useful model developed by disabled people. It recognises barriers that make life harder for disabled people. And removing those barriers creates equality and offers disabled people more independence, choice, and control. Not everyone uses the social model though. Not every disabled person is born or becomes disabled knowing what the social model is. So that's fine. That's absolutely fine, because language is always tricky and there are just better ways and ways to say things and better words to use. So why am I talking to you today? Well, every day as a wheelchair user, I live in a world that can make or break the way I feel about myself. I say this as the main message today. What we all do or communicate really does matter. So what Fiona said is language does matter. What we all do, it matters to me, and it matters to millions of people out there who get talked to or talked down to or talked at on so many different levels, and that includes sport and activity. So I've heard things like, you're just a bit lazy. Come on, just be active. She does it, why can't you? In the many campaigns I've seen over the years, the phrases that stand out to me are things like the disability burden, sitting kills, simply just sit less. And my least favourite advert was a skull and crossbones on a seat depicting how sitting down signifies death. I have never yet met somebody like me who has a mobility impairment say that campaign about death or making me feel bad about myself, it motivated me. Don't get me wrong, I'm sure there's one or two people out there, but there are just better ways to have a greater impact. And why does this cut deep to me? So, well, sitting down is my life. I don't have a choice. I am a wheelchair user. I'll be using my wheelchair for the rest of my life. I'm not a part-time user either. So I can't walk one step. Telling me to sit less or that it's killing me won't have an impact. But I am motivated by other things. So triggers that will probably motivate me to be more active or to move more. I can feel empowered to do a little bit extra or do something new. You just have to tap into the values that I have and what I can do rather than stating the things I can't ever change. And then in marketing, I've actually had the privilege to work with so many amazing people who are determined to make a difference with the way that they use their marketing. I worked on an activity campaign in Manchester that put inclusion at the heart of their messages, and it was called That Counts. It used inclusive imagery and messages like dancing with the kids, getting off a stop early, getting back out for the first time. It was simple, inclusive messages. And I want to finish by saying language changes over time. So new words come and go, but you can keep on top of this with the better guidelines out there. There are good practice guidelines out there, and involving the right people to co-design with you. We can all look at the words we use in our work and our personal life and ensure we are positive and not creating negative stereotypes. So we can support millions to be active and feel better about themselves quite quickly if we spend time on the words and messages that we use. So if you want to know more about us and Activity Alliance, it's activityalliance.org.uk, and our contact information is available on that as well. Thank you.
Sarah, thank you very much indeed. Some really powerful messages there from you, but also hopeful and encouraging and showing us how this can be done. And we all really should, as you say, with language changing. I'm sure we'll make mistakes, and we might even make mistakes on this this webinar today. But I think the message that the WHO guidelines have, the message that you've said, and the message shared by many in the development process from the audience and the wider community is that we do want to embrace the message you're giving. We do want to be inclusive. We need to learn, and we need to tap into, as you say, those positive messages of how to help everyone be more active and improve health. Thank you, Sarah. Stay online, of course, because questions are coming in, and I'd like to take the next 5-6 minutes to turn to the Q&A. And I mentioned already some questions. So Ulf, I hope you will join me and turn on your camera, because I'm going to pick up on one of the questions, which is clearly quite complex, but this relationship between being active and how much activity and being sedentary and this offsetting. And so we've got a question coming in from Australia, and it's asking whether that if indeed you the analysis adjusts for the amount of physical activity, is that actually removing the effect, or is the effect modification still in the analysis? Could you take on this question and just explain as simply as possible for the audience how confident we can be in that relationship you're saying, and of course, from a statistical perspective, respond to Lennart Veerman from Griffith. Thank you, Ulf.
Thanks for the challenge, Lennart. I suppose the most studies looking at sedentary time or sedentary behaviors and outcome statistically adjust for some measure of physical activity as a covariate. And then you can statistically say that there is an independent association if you find an association between sedentary behaviors and the outcome. In the types of analysis, if you do joint association analysis, you basically combine different groups of physical activity and sedentary time and compare those groups with a reference group. And we have used the most active and least sedentary as the reference group. And what we found especially in the Lancet paper and from all-cause mortality in the BJSM paper for CVD mortality and cancer mortality, was that there wasn't any difference between groups with high physical activity and high sitting time compared to the reference group, who was the, so to say, the best group. So that basically suggests that, or my interpretation of that data is that those ones who sit a lot but also have high levels of physical activity are not at an increased risk. But again, compared to the reference group, who also are highly physically active but sit much less. So it's always a comparison to the reference group. In the stratified analysis, you can basically compare whether the association between sedentary behaviors and mortality differ in different strata of physical activity. And if the association differ in different strata, as we did when we modeled CVD and cancer mortality as the outcome, and also all-cause mortality, but I didn't show those data. If there is a difference, so if there is a strong association in one strata, let's say the low active individuals, but no association in the highly active, then it's quite clear that there is a modification of physical activity on that association between sedentary behaviors and the outcome.
Thank you, Ulf. Let's see if there's going to be more questions on that line in the Q&A. Can I shift gear, Ulf, and keep you on the hotspot? Because there's questions which
maybe,
of course, are saying, when could we expect the quantitative guidelines? WHO guidelines, of course, speak to limiting high volumes. Everyone wants a threshold. And I'm wondering whether you could, in two parts, sort of, what's the evidence we'll need, and is it underway, and when might that be? And I'm listening for WHO's as well. Over to you, Ulf.
I suppose you plan to propose to launch the next set of guidelines in 10 years' time, or in 2030. So that's probably when you have the evidence. Now, I suppose large scale, even larger accelerometer studies than those we have today, large scale studies with devised measured physical activity, are more likely to provide an estimate or a threshold of a detrimental time when you are sedentary. And there are quite a lot of work going on. The ProPAS consortium is one of those big collaborations, and our consortium might be extended as well. And if we can then pool data from different consortia, that might be possible. And we know there are big databases freely available with accelerometer data, like the UK Biobank. So it could be possible to look into those ones. Then obviously we have all the issues with device measured physical activity, with monitor placement, intensity threshold, you name it. But I suppose when you're going to publish the new guidelines in 10 years' time, or whenever it's going to be, there might be evidence. I hope there is evidence.
Well, thank you, Ulf. I'm sure we all do, and you've pointed in your answer to, of course, the rapid change in the evidence with the use of device-based instruments, and how they're getting more affordable, and the larger pooled data and collaborations that are going on. Can I hand to Jasper, my co-moderator, and invite him to take over with some questions? Thank you, Jasper.
Thank you, Fiona. Thank you, Ulf. I'm sure we'll get back to you in a minute, but I would actually like to pose a question to Sarah as well. So Sarah, could you please turn your video back on? So we have a question in the Q&A, and also something that I think many of us have been thinking about and saying, okay, we obviously would like to communicate the right message, but how do we do that? So can you help us with some examples of how we should approach communicating our new guidelines using inclusive language? What type of words or what type of phrases should we focus on?
Sure, I touched on a few in my talk just before, but I mean, co-design and co-production will be the huge thing when you are doing your guidelines. You should be asking the audiences that you're working with what words work. And certainly the better campaigns that I've worked on are talking about the buzz of activity and being more active. They're not necessarily saying words that will put people off. So they're using things like move more, you know, things that say, you know, get off the bus stop early. It's words that actually talk about the fun aspects of being active, because actually, you know, most of us don't want to be Paralympians in our time. So talking about the buzz of the activity is much better, but involve the audiences that you're talking to. So actually ask them what would get them more active, because a lot of us will work with doctors every day. And certainly the people and family and friends will know more about us than actually the doctors.
Yeah, and there's another question slightly related to that in the Q&A that is asking about, would you recommend having different type of messaging for different types of disabilities, different types of people, I guess? My
personal belief is no, because I'm a person with different motivations, and actually I'm not governed by being a wheelchair user. So I think, and also even if you drill down to every impairment group, there's a spectrum. So you can't class one wheelchair user the same as the next wheelchair user, or, you know, so it's very, very difficult when you actually think about the hundreds and hundreds of different conditions out there that you're actually going to do a different guideline for each one of them. So I would probably say no, you could work on groups of impairments maybe, but certainly not on every condition.
Thank you very much, Sarah. I think we, as the last part of this question and answer session, there will be one more coming up shortly. I think we would like to turn back to you, Ulf, with a question that was also popping up in the Q&A from several people. How about the evidence for children and sedentary time? Is that something, how much do we know there, and what is the relation for children?
Then I tried to summarize it on one of my first slides, and the evidence is low, basically, if you're just going to summarize it, because the certainty of the evidence is low, and that's mainly because of lack of conducted longitudinal studies and well-conducted intervention studies. Most of the studies, or the majority of the available evidence, is still based on cross-sectional studies, and also still based on self-reported sedentary time. So I think, and in the paper Jean-Philippe Chaput published, or was the first author, published in IDA-BMPA, together with the physical activity or the WHO guidelines, we clearly identified the research gaps for children. So I recommend people to go to that paper, read the paper. It's free to download.
Thank you, Ulf. And it's also something that I can already announce we'll get back to at one of the next webinars that will in particular focus on youth. I'll hand back over to Fiona to end this Q&A session.
Thank you, Jasper, and thank you to our first two speakers. You're absolutely right. There's plenty of questions coming in, and particularly on youth, that will be addressed in a forthcoming seminar. But we're going to transition now from the science that we're getting to understand and know through these presentations, and thinking about the language we're going to use into promoting and intervening with the sort of programs, policies and actions. And it's my great pleasure to introduce our next speaker, Associate Professor Genevieve Healy. I think she'll be well known to many on this webinar. One of the at the forefront of the research in this field. an associate professor at the School of Public Health at the University of Queensland, and holding a number of honorary positions. Genevieve, you're known perhaps, at least some of your early work, for breaking up the sedentary time. And I remember your use of the infamous muscle biopsy methodology for data collection in some of your studies, etc., where we needed to know some of the biochemical changes going on. But today you're going to be presenting on slightly different work. You're going to be telling us about what we know about the interventions and how we can reduce sedentary behaviours. So great pleasure. Thank you for joining us. The floor's yours.
Thank you, Fiona, and hi everyone. I just want to thank you for the opportunity to talk to you today. It's an absolute I've just been coughing this morning, so please excuse me, but it is an absolute privilege and pleasure to be able to join you. I was tasked with the mission to provide an overview on what we know about how to change sedentary behaviour. And though it's in its relative infancy compared to physical activity, it is a rapidly growing and evolving field of research. So to be able to convey the key findings in the 15-minute window I have been given, I focus this talk on findings from recent systematic reviews with an emphasis on those that examined multiple different intervention approaches. This cherry-picked approach will obviously not fully address what we know about how to change sedentary behaviour, but will hopefully provide some insights into what we know works and where the evidence gaps are. But first up, I will just quickly revisit the WHO guidelines for sedentary behaviour. And I know Ulf has done this already, but it's good to just remember this before we go into looking about how do we change the behaviours based on the guidelines. So for children and adolescents, including those living with disability, the guidelines are to limit the amount of time spent being sedentary, particularly the amount of recreational screen time. This was a strong recommendation with low certainty evidence. For adults, including older adults, adults with a disability, those with chronic conditions, and pregnant and postpartum women, the guideline is to limit the amount of time being sedentary and to replace sedentary time with physical activity of any intensity, including light intensity activity. And all of these are strong recommendations with a mix of low and moderate certainty evidence. So how do we successfully intervene to support people to meet these sedentary behaviour guidelines? What do we know about what works? But before we look at the evidence around intervening on sedentary behaviour, it is important to highlight some of the key considerations around this behaviour that impacts on the types of intervention approaches and strategies used. So first up, sedentary behaviour is habitual and often occurs subconsciously. This means that it is likely that some form of prompting will be needed when intervening on the behaviour. And indeed, prompting has been widely used as an intervention strategy. This could be relatively simple, such as posters or fridge magnets, or time-based, such as computer prompts, or could be more individually tailored, such as through the use of wearables or text messaging. There are also multiple influences on sedentary behaviour, and these influences are also contextually driven, with the context varying by age and life stage. And as we've seen so vividly demonstrated through the pandemic, by broader societal changes. Understanding that there are multiple influences on sedentary behaviour is critical to be able to appropriately intervene and achieve sustainable change. So for example, an office worker's sedentary time is dependent on their job role and job tasks, their physical environment, such as access to equipment that allows them to be less sedentary while working, and the culture in their workplace and the extent to which less sedentary behaviour and more movement is normalised and supported. Importantly, sedentary behaviour is okay to do sometimes. That is, intervention should not target elimination of the behaviour. Rather, approaches need to be nuanced to be able to support more movement more often. We can see this play out in the targeting of prolonged and broken periods of sedentary behaviour in health coaching and associated intervention messaging. And the final consideration is that the evidence base, as you would have heard from Ulf, around the health impacts of too much sedentary behaviour is relatively new and still emerging, and many people are unaware of these health impacts. As such, an educational component can be an important part of the intervention strategy. There have been multiple different types of approaches that have been used to target sedentary behaviour, but they can be broadly categorised into three types: behavioural interventions that target and support the individual using tools such as mobile apps, activity trackers and educational workshops. Environmental interventions that involve structural changes such as activity permissible workstations or TV limiting devices, or even more broader changes such as building redesign. And multi-component interventions, which involves both environmental and behavioural components. What is really nice is that Blackburn and colleagues published a systematic review and meta-analysis last year, evaluating and summarising the evidence on the effectiveness of different intervention approaches to reduce sedentary behaviour across the lifespan, including environmental, behavioural, and mixed or multi-component approaches. Notably, they also looked at the complexity of the intervention and the relationship between complexity and effectiveness. And interestingly, for both children and adults, there was not a strong relationship between these factors. This relationship between complexity and effectiveness will be important to monitor and reflect on as the evidence base for interventions continues to grow. In their review, Blackburn and colleagues separated their findings depending on whether the intervention group was compared to an active or inactive control. The substantial majority of studies included in the children's component of their review compared the intervention findings to an inactive control, so focused on these results. Here, the meta-analysis showed that statistically significant reductions in sedentary behaviour have been achieved with behavioural and environmental approaches, as well as multi-component approaches. Only the multi-component interventions achieve significant changes in both the short and medium to long term. And they classified short term as 6 months or less and medium to long term as over 6 months. The overall mean difference was fairly modest at about 25 minutes per day in the short term and 14 minutes per day in the medium to longer term. The WHO guidelines for children include a specific recommendation around limiting amounts of recreational screen time. And there have now been multiple systematic reviews examining interventions that have aimed to address screen time in children and adolescents. In 2020, this evidence was summarised in an umbrella review of systematic reviews by Nguyen and colleagues. They found that overall, interventions were successful in reducing screen time, but the effect sizes were relatively small. So to understand what types of strategies are more successful, I looked into one of the more recent reviews by Wu and colleagues. They reported that interventions shorter than 7 months and those that involved health promotion or counselling were more successful than longer interventions or those that involved automated monitoring to control screen time. In summary, for children and adolescents, interventions have been able to successfully support the implementation of the guidelines regarding limiting the amount of time spent being sedentary, especially recreational screen time. We now go back to that same review by Blackburn and colleagues to look at the findings for adults. They reviewed a total of 77 studies, of which 62 were randomised controlled trials. They found that behavioural and environmental interventions resulted in a significant short-term reduction in sedentary behaviour, while interventions using a mix of strategies resulted in statistically significant reductions in sedentary behaviour in both the short and medium to long term when compared to an inactive control group. The mean difference overall was about an hour a day in the short term and about 20 minutes a day for the longer term. So larger differences than what were observed in the studies in children and adolescents. The differences were much less and not statistically significant when the comparison was an active control group. And of importance to note is that the heterogeneity of the results was high and the grade assessment demonstrated very low certainty of evidence. The systematic review conducted by Gardner and colleagues in 2016 helps us to unpack what this means a bit more. In their review, they described the behaviour change strategies used within interventions that have sought to reduce sedentary behaviour in adults. They found 26 eligible studies reporting 38 interventions, with just over half of these conducted in the workplace. And despite their relatively low quality, many of the interventions were able to reduce sedentary behaviour. The authors identified 18 behaviour change techniques that showed promise, with self-monitoring of behaviour, problem solving, and changing the social or physical environment showing particular promise. They also identified that education, persuasion, and training show potential as important functional elements for engineering reductions in sedentary behaviour. The authors recommended that interventions be designed to specifically target sedentary behaviour, and that designers consider using environmental restructuring along with self-monitoring, problem solving, and providing information on the health consequences of too much sedentary behaviour. And this recommendation ties in really nicely to the review findings from Blackburn and colleagues that showed that such multi-component interventions that use both environmental and behavioural approaches are generally the most successful. So now we know the findings overall for adults, I thought I would quickly summarise findings from some of the key settings or population groups. And one of the most common settings for change has been the desk-based workplace. Not only are there a lot of desk workers, but for this occupational group, the bulk of their sedentary time is accrued in the workplace. It is also possible to address multiple levels of influence on sedentary behaviour by intervening in this setting. Shrestha and colleagues have been active in systematically reviewing and updating the evidence in this rapidly evolving space. In their latest review published in 2018, they reported that there was low quality evidence that sit-stand desks may reduce sedentary behaviour at work in their first year of use, but there was insufficient evidence to draw conclusions on other intervention strategies, such as policy changes, use of computer prompts, or taking short active breaks throughout the day. However, addressing excessive workplace sedentary behaviour is an area where the evidence base is changing rapidly, thanks in part to strong industry demand to address what has been identified, at least in Australia, as an emergent work health and safety issue. And I would argue that we now have sufficiently strong evidence from both quantitative and qualitative data to show that interventions designed to reduce sedentary behaviour in the workplace can be acceptable to both employers and employees and feasible to implement. Another key population group is older adults. So Chase and colleagues recently published a systematic review and meta-analysis of interventions to reduce sedentary behaviour among older adults. They found wide variability in the intervention strategies used among the 17 distinct studies identified, with the strategies used including education, self-monitoring and goal setting. They did see an overall statistically significant effect for daily sedentary time. However, the reduction was relatively small. And notably, like we saw from the review from Gardner and colleagues, interventions that specifically targeted sedentary behaviour, either alone or in combination with physical activity, were more successful. Their recommendation was for practitioners to employ a diverse and wide range of strategies to reduce sedentary behaviour in older adults. So what about some of the other populations highlighted in the guidelines? Well, a scoping review by Gans and colleagues found three sedentary behaviour interventions on children with disability. The authors concluded that there was insufficient evidence to date to support the effectiveness of interventions to reduce sedentary behaviour in this population, and that more studies are needed. A systematic review by Coulter and colleagues on the effectiveness of interventions on physical activity or sedentary behaviour in people with multiple sclerosis concluded that insufficient data existed on the effectiveness of sedentary behaviour, with only 2 trials published to date, both of which use subjective measures. While a systematic review of sedentary behaviour in people with Down syndrome identified that despite high levels of sedentary behaviour in this population, only 2 intervention studies have been conducted, with only 1 of these reporting on changes in sedentary time. It's clear that more research is needed, specifically addressing sedentary behaviour in these at-risk groups. The evidence base on sedentary behaviour interventions is rapidly expanding. However, authors across the various systematic reviews identified several common future research needs. These included the need for more randomised controlled trials with appropriate comparison groups and with objective measures used where possible. There is a clear need for more evaluation of the long-term impacts of these interventions and on impacts not just related to changes in behaviour. The bulk of the interventions to date have targeted relatively easy to reach populations. Now that it is clear that reducing sedentary behaviour is possible and is acceptable in these populations, it is important to continue to expand the research field to include participants from a wider diversity of populations and settings and with a mix of health conditions. It's also important that interventions are designed for dissemination. This includes testing potentially scalable and low-cost, no-cost approaches in real-world settings, as well as partnering with industry to evaluate large-scale projects such as building redesigns. So what are the take-homes from this quick overview? Well, critically, the evidence to date has shown that interventions can be effective for helping people meet the WHO guidelines for sedentary behaviour. Many different intervention approaches and strategies have been shown to be effective, but importantly, the more approaches and the more complex the intervention does not necessarily make it more effective. We do need more evidence on the sustainability and long-term impact of the interventions. However, I think there is an exciting opportunity to rapidly generate evidence, including practice-based evidence, by leveraging off the increasing community awareness of the impacts of excessive sedentary behaviour and the industry demand for effective solutions to address this public health concern. Thank you very much, and again for this opportunity, and I look forward to the discussions arising from this.
Thank you very much, Genevieve. And I can see that there are already questions coming in the Q&A, which we'll go to shortly after the next speaker, because now I have the pleasure to introduce our next speaker. And our next speaker is Christine Hansen from a Danish company called OfficeFit. And Christine was one of our master students 6 or 7 years ago, and I'm very happy to see that she moved on from being a student to now being working within this field, and she will tell us a little bit more about not the research in interventions, but the actual practice in interventions. Christine, please, the floor is yours. Start sharing your screen.
So I hope you can see my screen.
Yes, thank you.
Yep. All right. So first of all, it is such a pleasure to be with you on today's topic. And Jasper, thank you so much for the fine introduction of me. I'm going to jump right to the how we at OfficeFit implement a concept which has brought us our success with reducing sedentary work behavior. This concept has its roots in the evidence, but also in our experience and evaluation of what works in the field. And with this said, I'm going to start with a video that will give you an introduction to the concept, which we have named the OfficeFit concept.
As human beings, movement is central to our lives and well-being. However, technological advances continue to replace a greater and greater part of our daily physical activity. We are sedentary in the car or bus to and from work, and 6 to 10 hours more in an office chair. Afterwards, we spend the evening on the couch watching Netflix. While we have a bad conscience about our lack of activity, we still end the day exhausted and with no energy. Our inactive and sedentary behavior is the dominant cause of obesity, muscle tension, and pain in the body, all of which inhibit our well-being and job satisfaction. In the long run, the consequences are an increased risk of developing type 2 diabetes, cardiovascular diseases, and certain types of cancer. Type 2 diabetes alone has tripled since 1995. But it does not have to be that way. It's all about habits and behavior. We can make a choice to change the status quo and bring movement back into a sedentary workday. Making this change and building an active, fun, and energetic workplace culture is central to our work at OfficeFit. We look forward to introducing your staff to our motivational team and easy-to-use app. Let's create a culture centered around daily movement and well-being together. Become an OfficeFitter.
So I'm quickly going to move on. I hope the video outlined that at OfficeFit, we focus on the workplace and the possibility this arena gives us to reduce sedentary work behavior. If we focus on the woman from the video, let's call her Michelle, it is at work that she spent most of her day and where she can make a real difference for herself, her workplace, and even the society in terms of getting healthier without changing her busy family schedule. And this is exactly the problem, the opportunity that OfficeFit addresses. At this point, I hope it's clear that OfficeFit is neither another furniture retailer just delivering office equipment. At OfficeFit, we want to change behavior, and therefore one of our core values is that we respect people as they are, and we know that people have different starting points and motivations. Some might be ready to use a desk bike while working. Others have never thought of doing active breaks or changing their position several times during the workday, or try to have more active meetings. Therefore, the OfficeFit concept is centered around both different types of office equipment, but more importantly, a number of motivating features supporting an active working environment, which I've listed in front of you. I will just jump to the introduction of the implementation of the concept, which we by now has implemented in more than 200 firms, being both private, public, and international. If we were to implement this concept at Michelle's firm, the first thing we would do is meet with the leading team. This meeting gives us an understanding of the culture and the composition of the employees, which allow us to tailor parts of the concept to the firm and its different departments. But it also allows us to make sure that Michelle's leading team know how vital their support and engagement is if they want to succeed with a new and active work culture. The next thing we do is we deliver the equipment and then make a presentation for all employees and the management. This presentation is the official kickoff to a new and healthy work culture with less sedentary workers. At the presentation, all the questions related to why and how are answered in a language and in visuals that are relatable and easily understandable, which I hope my presentation is an example of. In our experience, the compliance to this presentation almost equals the success of the concept. And we get told that it's because that people, if we keep playing that it's Michelle and her colleagues, they are provided with information about a critical health issue, but also a manageable solution that they can support each other in. And from the field, I can inform you that it truly is an eye-opener for many that every move actually counts and that the guidelines has emerged on sedentary behavior. At the presentation, we make sure that everyone knows their health ambassador. Together with two other colleagues, Michelle has volunteered to be a health ambassador, and this means that she's our main contact person and has agreed to be a first mover and launch activities and challenges that continuously stimulates a working environment that is fun, social, and active. Every month, our motivational team is providing Michelle with a short to-do list so she and her two colleagues can easily launch the features within the OfficeFit calendar, which is our activity calendar. And this calendar is also introduced at the presentation. The calendar follows the year and is of course renewed every year. The calendar gives Michelle and her colleagues something to look forward to and socialize over. Every month, each employee is provided with information regarding the monthly theme and the two challenges being both an app and a non-app challenge. The calendar is hung at Michelle's workplace and is together with the equipment making the active office culture visible and more importantly, easily accessible. As mentioned, the activity calendar works closely together with the app. So the app is, of course, also introduced at the presentation. At this presentation, we go through the possibilities within the app where we use these gaming features to motivate Michelle and her colleagues. As an example, she can track her sedentary and active time, which give her a clear indication of the changes that she's making for herself. She can also make a personal or social challenge centered around virtual rewards, energy use, and routes. I've drawn one in front of you. And with this note, the app actually holds an algorithm that can convert time spent standing into kilometers, which promote the use of adjustable tables. Michelle can also use the app to prevent or target existing muscle pain by putting together a program of exercises. And in addition, she and her colleagues can join active breaks or breathing exercises. After this presentation, a 90-day program follows. And this program ensures that Michelle and her colleagues get the best possible start into the new active culture. This program is a brush up on why and how, and is meant to strengthen the motivation and the work community around a workday where every move counts. At this point, I think it's vital to mention that we're constantly evaluating how everything is going at Michelle's firm. Every month, Michelle and her colleagues and the leading team can let us know by using 3 different smileys. If we get a red smiley, our motivational team will act right away and call the health ambassadors to find a solution, which can be many different things. Among others, it can be a new and relevant route challenge, or it can be another motivational presentation. So at OfficeFit, we know that it takes time to change behavior and combat potential ills that follows with sedentary work behavior. The timeline you see in front of you runs at least 2 or 3 years after the presentation has been made, so we're sure that we make this change. This also gives us the opportunity to follow the impact that the concept has on public firms' sick leave and private firms' stress levels, and some employees' use of medications, which are actually real life examples of what we have succeeded with over the last few years. In total, OfficeFit has existed for 5 years and has grown from 3 to more than 20 employees, emphasizing the need and interest in a concept that can reduce sedentary work behavior. It is our belief that we are succeeding with this concept because we are listening to our target group, and in this case, it's being Michelle and her colleagues. This constant evaluation and open dialogue enable us to improve the OfficeFit concept and expand it with new initiatives like the Get Up Assist and the OfficeFit Home Edition that includes live sessions and practical examples of how to stay active while being at home, which I think is the situation for many of us at this point. Looking into the future, it is our hope that at some point just going to work is motivation enough to reduce the sedentary work behavior. This could be possible if we from a young age gets introduced to a healthy way of working and associate workplaces with variation and movement. Then we could all be our own and each other's health ambassadors. On this note, I have to say that OfficeFit is also working towards introducing an active working environment at schools. And we do this because our young generation is our next adult generation who goes to work every day, just like the person in this PowerPoint called Michelle. I think this was my 11 minutes, so I'm quickly going to jump to a picture of myself. And if you want to know more, you're more than welcome to ask now. Yep.
Thank you. Thank you very much, Christine, for your presentation and for showing us, I think, a real world intervention that that companies are actually willing to pay for. And I think that's perhaps also a first question that I would like to ask you, Christine, is how do you convince, what is your convincing arguments towards the company? So how do you convince them to hire you to do this for their workforce?
So I think that all companies can agree to that their most important asset is their employees. And if you want healthy employees and you want more productive employees who are happy and want to go that extra mile for the firm, you have to invest in them. And you can invest by making sure that they feel healthy and embraced at the workplace. And the concept that we implement comes with the fact that we actually embraces every employee and they have the ability to be a part of the process. So when we meet up with the leading team, we tell them all the goods with the concept, and it's hard to say no to, I must say. I have to say that.
Thank you very much, Christine. I'd like to invite Genevieve to come back on, and we're getting lots of questions, so I want to thank the audience there, and we're not going to be able to get to them all. You know, we're up against the time already. Genevieve, question here, and I might come back to Christine too. Quick answers if you wouldn't mind. Financial rewards. Genevieve, in the literature, can you think and tell us anything about the use of incentivizing through financial rewards? Is it in the literature yet? And we'll turn to Christine about if employers are doing that. Genevieve.
Yeah, and I haven't researched this, so it'd be an off-the-cuff answer. I know for workplace health promotion programs, they've seen that financial incentives can work. I'm sure it would probably apply to these type of interventions as well.
Yeah. Still more research is then to the audience. Thanks for the question from the audience. Christine, any comments on that from your knowledge? Are employers incentivizing with financial rewards in any way?
Financial rewards? No, I think more virtual rewards is the way. And well, sometimes we'll give them a cup or something. We'll actually drive out to them in order to applaud that they did a change. So, but no financial awards in our mind. No.
All right, thank you. Let me go back to Genevieve. Question about the self-monitoring. You mentioned, I think it was in one of those studies, I've lost the name of it, but where self-monitoring was showing promise. Can you tell the audience what you mean by that, what devices or what way, and tell us what your thoughts are on that as a promising direction?
Thanks, Fiona. And self-monitoring can be I'm not wearing my wearable today. So wearables, that's a really useful way of monitoring your behaviour. It can be as simple as just a bit of paper and tracking the amount of time that you're being less sedentary and taking active breaks. So it can be as simple as that. It works because, like I was saying before, that sedentary behaviour is so habitual. So having that something to monitor how much you're doing, a lot of our participants are really surprised when we put active powers or something that measures it very precisely on just how sedentary they are and those big long danger zones of those prolonged periods of sedentary behaviour. So monitoring your behaviour, raising the awareness of it, recognising that it is very habitual and being aware of that. That's why it really works as a self-monitoring tool, as it does for physical activity as well.
And Christine, we're all working at home a lot more and for a lot longer than we hoped. And 2021 for many is going to involve this teleworking from home. I'm crouched at my dining table here. How are you coping? Can you give us any ideas? Are you taking some of those ideas from the workplace into the home place?
Oh, definitely. Actually, at this moment, I'm in between a desk bike and a treadmill. I just returned my desk bike and I'm waiting for my treadmill to arrive. But yeah, for sure, I'm making sure to do something every 20 minutes. I set an alarm. I stand up, and then I actually use my ironing board able to make like an adjustable table for myself. At OfficeFit, it's all about making the variation into the day. There's no right way of sitting or standing. It's all about making the movement and making more movement. So I look like this crazy woman with an ironing board next to my table, so I have the opportunity to keep changing the positions. Yeah.
Well, thank you very much for the answers, and have given us a few tips there. My ironing board is getting used as a desk too. And it really, Genevieve, we've got to translate some of this into practice. Are you optimistic we're ready to take some of the review findings into practice? You're nodding vigorously. Final remark, Genevieve.
Yes, I run a big free workplace health promotion program. It is called Be Upstanding, which I recognise is, there's language issues around that, but we've been running that. It's free online program since 2017. It provides workplaces with resources, strategies, tools, and an evidence-informed program to support them to sit less and move more at their workplace, or be less sedentary and move more at their workplace. And what's good about it is that there's low cost, no cost approaches that they can do as well. So yes, we are already ready to go into practice, but we also need the evidence base continuing to happen as well. It's a very interesting state in the sedentary behaviour field and interventions.
Thank you, Genevieve. I think we're getting down to the last 10 or so minutes, but we've got questions still coming in from our earlier presentations. And I want to invite Ulf to come back on and join us again, because it popped up several times. Ulf, you may have seen it. People are asking about what the mechanisms are. It's fantastic, all this epidemiology that's showing us and the relationship, but what's going on? Can you share with us what are the mechanisms?
I wish I was a physiologist. I'm not. I don't know, but I mean, from my understanding, I think most of the mechanisms are actually the same as those ones who are induced by physical activity. So in my opinion, it's basically the reverse. So if you increase your physical activity, you have loads of physiological changes, which are basically the opposite of what happens when you're sitting down. I'm not entirely sure there are any unique biological mechanisms associated with sedentary behaviors, but I might be wrong, and maybe Genevieve want to comment on it as well.
Yeah, I was going to make the same suggestion. Genevieve, can you add anything or point readers, audience to anything in the literature? And of course, this is a topic to pick up on. Genevieve, join us again.
No, now I'm going to get caught out because I was answering a question in the Q&A. What was the question again?
Mechanisms, underlying mechanisms of sedentary behaviour to these health outcomes, which predominantly are some of the diabetes, cancers and metabolic, maybe mental health, but any comments on the mechanisms?
Yeah, and the expertise for this lives down with Professor David Dunstan and the crew down at Baker Heart and Diabetes Institute. And they've done some fantastic reviews on that. But really, it's about the muscle unloading activity and the vascular impacts of that as well. So the metabolic and vascular impacts. And it's a very emerging field around the physiology. And people like Patty Dempsey, who's I know been on the board, have done phenomenal reviews. So rather than me trying to fumble through, I suggest bring it, have a look at the amazing work that he's done as well.
I'm sure Jasper's putting that on the list of the potential topics for the future. Can I comment on before handing to Jasper on a question that's a very important one about the that we now have sedentary behaviour guidelines, physical activity guidelines. We've got these global guidelines, but there are national guidelines, and there's been a question by the audience about the confusion. And that's really important. And someone said, can we just have one set of guidelines? Let me offer to you that that's the reason WHO invested a lot of money, a lot of time, and drew on a lot of expertise to create the global guidelines for all countries to adopt. And that's the work we're into now, with many of you all helping in this webinar series. So that countries can adopt the guidelines, which are based on the best available evidence and science. We don't want to spend money, as another question's asked, directing it towards more guideline developments. We want to now move on to the interventions and practice. Ulf said maybe 10 years. It probably will be 10 years, although I think if the science grows within 5 years, that would be pragmatic when maybe there could be some update. But absolutely, we've got to move on to implementation, and this has been a kickstart to some of that dialogue with it, including on the language about how we implement. Jasper, I see the clock. I'm going to hand back to you.
Thank you very much, Fiona, but you are touching on some very important topics that I'm sure a lot of people in the audience were wondering about. So as you have heard, sedentary behavior, there are a lot of questions. There's a lot of research out there, but also a lot still to be done the next 10 years. And one of the groups who is working with that is the ISPAH Sedentary Behavior Council. And I would like to invite Audrey to give us a very brief introduction to what ISPAH is doing on sedentary behavior in a Sedentary Behavior Council. Audrey, yes, please.
Yes, thanks, Jasper. So I just would like to give you a brief glimpse on the Sedentary Behavior Council, its mission, and our upcoming activities. So the council is now led by Aoko Wyoming from Nigeria and myself since October 2020, and we're receiving the stellar help from our secretary, Paul McKee. If you want to have details about the council, you can go online to the address that is at the bottom of the slide. But otherwise, let me give you a brief overview of the mission of the Sedentary Behaviour Council. So our mission is articulated around 5 main goals. We aim to advance science related to sedentary behaviour research, to contribute to evidence-based advocacy, to support any practice of sedentary behaviour change, to contribute to education and build capacity. And so for this, we're trying to work with the members of the council. And here I'm showing you examples of some of the planned activities we're thinking of for 2020-2022. We're going to keep sending newsletters to our members. We are also going to keep doing or renewing our mentoring workshop. We had the first workshop launched in October 2020, and we'll have a new one in 2021. And this is a great opportunity for any early career researchers. We're also going to launch new webinars that will be much more specific to the science related to sedentary behavior. We are thinking of starting a systematic review, still thinking of the topic, for which we would like to invite any members to contribute. And finally, we would like to work on creating a platform in which we will have axiometers that could be made available for researchers, especially those from low and medium income countries. So these are just brief overview. If you have any interest in contributing to any of these activities and joining the council, please do. Everyone is welcome. And if you have any question, contact myself, Paul, or Aoko. Thank you very much.
Thank you very much, Audrey. And yes, I would definitely encourage the audience to have a look at this and join if you are interested to learn more and contribute to this growing field. And while I will give the floor to Fiona to have some closing remarks on behalf of WHO, I will also like to use this 10 seconds to point you to this QR code where you can find our feedback survey for this webinar. Fiona, the floor is yours.
Wow, well, thank you, Jasper, and thank you to all the panelists and speakers this evening. It's really been a tour de force. Thank you all for setting the scene with the science, and we gave you a big challenge there, more to discuss, more science and questions to explore. And I see David Dunstan has joined us, so I'm sure we'll be wanting to loop back to get more science on the mechanisms as this field unfolds. The language was so important, and thanks to Sarah for really bringing that to the fore with her passionate intervention, telling us about how, for all of us, we've got to watch what we say, how we say it, and our actions, so we can really truly build this inclusive movement and health for all. The interventions, thank you so much to Genevieve and to Christine for the insights of science and the working practice, really bringing it to life, that we have really got a lot of opportunities to reduce sedentary behaviours. And I want to remind everyone that, of course, this recording is going to be available, so that if there's more to listen again, to share it with colleagues, we will be posting the recording of this webinar on the ISPAH and on the WHO website. And thank you to the speakers telling us about the ISPAH Council, a way to get involved in this. Very interesting, enjoyable, not long enough, and we've had over 300 plus people join us tonight. Thank you to all of you. Many of the guideline development group are on this call. I want to extend another thanks to the hard work that you did to make the guidelines happen. I want to thank those who have joined from WHO, country offices, regional offices, and other colleagues. And to all of you who this might be your first time joining, we hope you come back. There is a series that Jasper will speak to. And for all of you taking the time, whether in your day or evening. So I think the message is we all need to move more and keep sharing the knowledge. So thank you very much on behalf of WHO for the organising from ISPAH and the colleagues behind the scenes making this happen. A lot of work goes on and we appreciate this and we look forward to the next. And Jasper, I hand back to you.
Thank you very much, Fiona. Yes, and with that, I think my only job now is to actually tell you a little bit more about the next webinars. As we told you before, this is a series. For some of you who are here for the first time, there's more coming. There is information here as well to two different newsletters. You're very welcome to join up. But what I was actually getting at, where is the slide? There we go. Our next webinars. So we've listed 3 dates, and these are save the dates with the topics here. So we look very much forward to seeing many of you at these events, or at least some of them. Again, you know where to find us by now. Look at our website, sign up, and the recordings will, of course, also be available there. As I said, if you want to know more, want to keep up to date, sign up. Either to the Sedentary Behavior Council website or to the ISPAH newsletter. Have a look at becoming a member of ISPAH. And with that, I think I would like to say thank you all very much for attending, and hopefully we see all of you again in about 2 months' time after a little Easter break. Thank you very much.
Are we live to